Hi everyone, my name is Stephen Schell. I'm a student in the Family Nurse Practitioner program. I'm here today to speak about two separate issues. Number one is the issue of bacterial resistance to antibiotics, and the other is a common childhood infection called acute otitis media, or AOM. This illness is one of the most prevalent around the world, with an estimated 50 to 85% of children acquiring the infection for the three. This equates to about 700 million new cases around the world annually. The standard treatment is with amoxicillin, usually a 5 to 10 day course. Just the sheer number of children infected and the frequent use of antibiotics creates an environment that is likely to encourage microbial resistance. The CDC estimates that within the United States, about 2 million people per year are infected with resistant bacteria. Of those, 2,300 die. Advanced practice nurses have an opportunity as providers to influence the progression of this health issue, specifically as it relates to non-severe cases of AOM in children, by understanding when antibiotics use is appropriate. The purpose of this presentation is to review the available literature to determine how fever and pain management and an observational approach compared to antibiotic treatment affect the resolution time of non-severe AOM infections in children. The three studies we'll be looking at today were sourced from the EKU online library. The first article was a randomized control trial by Dr. Spiro and his colleagues. The study tested whether the use of a wait-and-see style of care could be effective and to observe from the effects of clinical symptoms and the adverse effects related to antibiotic use. This is done by having half of the children diagnosed with AOM receive a prescription for antibiotics to be used immediately, and the other half to receive the same prescription and only to be used if symptoms were not better or worse. Medications to control pain and fever were provided to both groups. The study found that 62% of the wait-and-see group did not need to use antibiotics during the course of their illness. There was not a significant difference identified between groups when looking at fever and ear pain. The rates in adverse antibiotic-related outcomes like diarrhea were found to be 2 to 3 times higher in the immediate use group. A second study conducted by Dr. Hoberman and his colleagues, the study was designed to observe the clinical response and failure rates when comparing children taking a 10-day course of amoxicillin compared to placebo. Parents were also instructed to provide acetaminophen for pain and fever control. The study found that the use of antibiotics did resolve symptoms more quickly both in initial and sustained measurements. In addition, this group also had lower rates of clinical failure. Diarrhea and diaper rash were found to be more common in the group using antibiotics. And nasopharyngeal cultures were collected in the study, but it was concluded that there was no significant changes in either group in the development of resistant streptococcus pneumonia. Despite the fact that symptoms did resolve more quickly in the antibiotic group, it was impressive to see that about 53% of the placebo group also achieved sustained resolution of symptoms in the time frame. The last study was conducted by Dr. McCormick and his colleagues. In this study, half of the randomized group received antibiotics immediately, and the other half were assigned to a group only receiving medications for symptom control. It was found that the antibiotics provided resolution of symptoms more quickly and with smaller rates of clinical failure, but with higher rates of antibiotic-related adverse events. Despite this, 66% of the non-antibiotic group completed the study without use of antibiotics and were found to be less likely to be carrying resistant cultures of streptococcus pneumonia. The findings of these studies are clear in showing that early antibiotic use leads to earlier symptom resolution, but the benefits need to be weighed against the high rates of adverse outcomes related to their use. All three studies stress the use of a very stringent diagnostic criteria. This, as well as parent education, symptom management, and having effective antibiotics when needed, are the key points to be incorporated into the future of AOM treatment. The knowledge that a percentage of these participants were able to overcome their infection without use of antibiotics, combined with the current concerns of antibiotic-resistant bacteria, leads me to suggest a more conservative approach. Further research into a wait-and-see type of practice for confirmed non-severe AOM cases, combined with parental education and symptom management, provides the confidence that a child will be comfortable, but also allows for antibiotics to be available if conditions worsen. This scenario will likely work best within a primary care setting where patients and families are comfortable with their provider and are confident that they'll be able to get follow-up care if needed. The current concerns for antibiotic stewardship and the high incidence of this illness cause any changes that decrease the amount of antibiotic use to have a potentially big impact on the health of children and the responsible use of antibiotics. Thank you.